Hey, doctors in training. How strong are your renal pathology skills? If you want to give it a test, come on and participate in a walkthrough of a USMLE-Style vignette here on MedUPTICK. Welcome back. Let's systematically walk through this question to evaluate the various answer choice possibilities to arrive at the correct answer. Which of the following is the most likely diagnosis? A 45-year-old African-American man presents to the clinic with new onset swelling in his legs and foamy urine over the past several weeks. When I read this first line, my mind goes to nephrotic syndrome because the symptoms are classic. Excess proteinuria, indicated by the foamy urine, results in hypoalbuminemia. The diminished serum albumin leads to the patient's new onset lower limb edema due to fluid leaking out in the vasculature, settling in the interstitial tissues, and hyperlipidemia. He has a history of hypertension managed with amlodipine and does not smoke, drink alcohol, or have diabetes. Physical examination reveals 2+ pitting edema in both lower extremities. His blood pressure is 150/90. One thing to note here is one of the most common adverse drug reactions of amlodipine, a dihydropyridine calcium channel blocker, is bilateral lower extremity edema. He remains hypertensive, indicating he likely requires a secondary adjunct medication to get the hypertension under control. Laboratory findings are as follows. Serum creatinine 1.8 milligrams per deciliter, serum albumin 2.8, urine protein 4+ on dipstick, urine protein to creatinine ratio 5 significantly elevated, urinalysis no red blood cells or cast, serum cholesterol 300 milligrams per deciliter. The labs are notable for elevated creatinine and urine protein to creatinine ratio signaling impaired renal function. The normal range of serum creatinine is typically 0.7 to 1.2. The low serum albumin, normal range 3.4 to 5.4, is unsurprising because the patient presents with proteinuria, foamy urine. For context, 0 to 14 of protein represents the normal range in urine. 1+ signifies 30 milligrams per deciliter, 2+ refers to 100, 3+ to 300 milligrams per deciliter, and 4+ is 1,000 milligrams per deciliter. The absence of cast and red blood cells eliminates the concern for hematuria, ruling out glomerulonephritis and IgA nephropathy, and decreases my suspicion of infection. Finally, the serum cholesterol is elevated, with normal being less than 200 milligrams per deciliter, which indicates hyperlipidemia supporting nephrotic syndrome with liver compensation. A kidney biopsy reveals segmental sclerosis of some glomeruli with foot process effacement on electron microscopy. The biopsy is key to identifying the specific cause of nephrotic syndrome. Which of the following is the most likely diagnosis? Based on the details of this vignette, we can come up with a list of differential diagnoses, which include Fabry disease, drug-induced nephropathy, thrombotic microangiopathy, renal amyloidosis, and focal segmental glomerulosclerosis. Now we can move on to review the answer choices. A. Minimal change disease. Minimal change disease is a nephrotic syndrome with classic symptoms of proteinuria and hyperlipidemia present in the vignette. The biopsy findings of minimal change disease show podocyte effacement, but they do not demonstrate sclerosis. Additionally, this is typically seen in children. B. Focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis is a leading cause of nephrotic syndrome in adults, especially African Americans. The biopsy findings of podocyte effacement and sclerosis are classic findings for focal segmental glomerulosclerosis. The vignette also shows hypertension and reduced renal function, which makes this the most likely best answer. Therefore, I will eliminate answer choice, which is minimal change disease. C. Membranous nephropathy. Membranous nephropathy is typically seen in Caucasian adults with nephrotic syndrome. The vignette biopsy is inconsistent with membranous nephropathy, which would show thickened glomerular capillary walls and subepithelial immune deposits on electron microscopy. I will eliminate this answer choice. IgA nephropathy. IgA nephropathy typically presents with hematuria, nephritic syndrome, and the biopsy would show mesangial proliferation with IgA deposits. These complete vignette inconsistencies rule out IgA nephropathy. E. Renal amyloidosis. Renal amyloidosis presents with nephrotic syndrome and kidney dysfunction consistent with the vignette. However, a biopsy would show amyloid deposits that stain positive with Congo red. Option E is ruled out. In conclusion, focal segmental glomerulosclerosis is the best answer to this question. It is my sincerest hope that this question has refreshed some high-yield details about multiple renal nephropathies. If you've enjoyed it, make sure to click the like button. Drop your feedback in the comments so the content on this channel reflects your interests. I'm here to help you achieve your best USMLE results, so make sure you don't miss another deep dive question walkthrough by subscribing and turning on those notifications. Until next time, stay sharp and focused, and continue to elevate your clinical mastery.